reportable diseases section. As you probably already know, this series this month has been focused on Legionella and water management. Dr. Johnson asked me to talk today with you about Legionellosis, the process of case investigation, and what we do here at the state and at the local health department, kind of the process we go through when we get a case up to when it's reported as an HAI and what happens then. Thing to go. Here we go. So the learning objectives are so you can understand thorough case investigation, the importance of it, and the roles of the local health department in outbreak investigations, have a better understanding of outbreak detection, investigations, and response activities in epidemiology and environmental health, and recognize the value of an effective water management plan for healthcare facilities. Okay, make sure my things are going right. I know some of you have heard the previous presentations in the series this month based about water management plans. But for those of you not, I'll be touching briefly on some of the topics already covered in the previous presentations, as well as public health process, and hopefully tie the series together. Since I'm the last to present, I want to give an overall kind of summary of the water management series and provide an overview of Legionella and public health actions. I'll briefly be going over Legionella, the bacteria, and Legionellosis, the disease. Briefly, I want to mention the Legionella trends and reporting requirements, but then I'll get into what happens on the public health side here at KDPH and at the local health department. I'll cover how we at public health learn about a case and how they're investigated and reviewed, and some of the processes we go through until it ultimately gets reported to the healthcare facility as a possible HAI infection, and the investigation to determine that. Hopefully tying everything into what the previous presenters have already presented on, and summing up why water management is so important. So basically, Legionella, what is it? Everybody's probably heard this, but it's a gram-negative bacteria. It occurs naturally in water and soil, but at low levels. It's found in lakes and streams and underground water sources. It's also found in soil and can be found in bagged potting mix because that sits around in the heat and the sun, and it's moist and damp in a bag. But and there has been cases of Legionellosis with exposure to that, but those are rare, and the only cases I've heard of are in Australia. But I did want to mention that it is possible. There are at least 60 species, and most are considered pathogenic, but most of our cases are Legionella pneumophila because it's the most common, because basically I assume it's because the most common test we use is the urine antigen, which can only detect Legionella pneumophila 1. So Legionella, the bacteria, it exists naturally, but low levels. And as Dr. Johnson mentioned in her presentation, public water filtering can't remove all microorganisms from the water, so it's there. And the bacteria likes to hide in biofilm and pipes and devices and multiply within the amoeba and the ciliated protozoa. It's protected in there from extreme temperatures and adverse environmental conditions. So it can be hard to detect, and it because when you try to do environmental testing, it may not be in the area you've tested. It can be somewhere in the system, kind of hiding out there. You test for it, you don't detect it, but then it can move and go to an area that can cause infection. So our man-made water systems create a nice place for this bacteria to hide and grow. It loves the warm, slow-moving, stagnant water with low disinfectants, low pH. All those can provide the environment that'll let it multiply to levels that can cause illness. some other factors that can contribute to the growth is excess biofilm, temperature fluctuations, sediment and debris, and corrosion that can use up the disinfectants. Of course, the healthcare facilities have large, complicated building water systems that can provide these conditions. Then it can move to an area where exposure can happen. So fluctuations of water pressure, like water main breaks or vibrations from maintenance or construction, it can move then and expose people and cause illness in a susceptible host. This is why Legionnaire's disease prevention includes preventing stagnation by flushing stagnant faucets, shower heads, and such, ensuring adequate disinfection, maintaining water temperatures outside of the ideal growth range, maintaining devices to prevent sediment and scale corrosion and biofilm buildup. These are all addressed in a good water management plan. We want to keep it from growing to begin with. A proper water management plan is highly recommended for any healthcare facility and at travel facilities like hotels, resorts, cruise ships, riverboats, Airbnbs, all those should have a good water management plan. So it's been growing. The bacteria has been growing in the potable water. But to cause illness, there's got to be some exposure. It's not just going to get it from the pipes. It's got to get in the lungs to cause pneumonia. This is usually occurs when someone inhales aerosolized contaminated water, or in some instances, you can also get it from aspiration on water too. The most common sources of this exposure are from your potable water for your shower heads and faucets, cooling towers, decorative tubs, that kind of thing. It loves warm, but so it's surprising that it can also be harbored in ice machines. The warm heat from the motor can allow it to grow inside an ice machine. It gets frozen into ice, but that doesn't kill it. And then when it melts and someone aspirates on that, if they're susceptible, have a weakened immune system, they can then get sick. It's not spread person to person, so you don't have to worry about isolating your patient, preventing them from exposing others. So it's naturally occurring. It's found a nice, comfy place to multiply. It needs a susceptible host to be exposed. Again, often this is done by aspiration of contaminated water or from inhalation of aerosolized water. And there have been cases of wound and surgical infections that have occurred after contact with contaminated tap water, but those are rare. Literature has shown that there were cases mostly in the past that were in newborns that were birthed in birthing pools that had contaminated water. But again, that's rare. I've never seen that here in Kentucky. I've just seen it in some literature. So it is a potential possibility. Again, we usually see pneumonia. There we go. So not everyone gets sick. Most healthy people exposed might not get sick, or if they do, they have a mild illness, a flu-like illness, which we would call Pontiac fever. But who's more susceptible to getting a severe illness? Your people at increased risk are your current and former smokers or people who vape. 50 and older, people with weakened immune systems and certain chronic health conditions are at increased risk. Chronic lung disease conditions like emphysema and COPD, or anything that reduces your immune system, like cancers or HIV, AIDS, diabetes, renal failure, and hepatic failure put you at increased risk for developing severe illness from exposure to Legionella. So once it's grown to high enough levels and a susceptible person is exposed, it causes infection, which we refer to as Legionellosis. Everyone's heard the story about Legionella, how it got its name from the outbreak at the American Legion in Philadelphia in 1976. Cases occur year-round, but we definitely see an increase of cases in the summer and early fall, which makes sense because it's hot. It likes warm weather. I wanted to know, it usually affects the older people with underlying conditions, but recently we've seen increases in healthy younger adults that have acquired community-acquired pneumonia from Legionella. Not real sure why that is. The amount of dose you're exposed to can have an effect on how sick you get. I don't know, maybe individuals were run down, already had something else going on, but we have seen it more in younger people and people that don't have a lot of comorbidities that would cause them to be more at risk. Outbreaks are usually associated with the complex water systems like hospitals and long-term care facilities, hotels, and cruise ships. So we developed Legionellosis. We use the term Legionellosis for surveillance purposes to encompass all the different forms, which are Legionnaires' disease, which is the pneumonia that's diagnosed. And the diagnosis can be clinically by the doctor saying that pneumonia. If it shows up on radiographs like CTs or X-rays, or if signs and symptoms are there for, if it's not explicitly said that they have pneumonia in the records, if the signs and symptoms match and they have a positive lab, that is considered a confirmed case of Legionellosis. Pontiac fever, on the other hand, is a milder illness. It's flu-like, and it's self-limiting, resolves on its own, and they don't have pneumonia, but they have to have some symptoms along with, and a positive laboratory can help confirm that. But not all Pontiac fevers are diagnosed with a positive lab. Often we find those because they're linked to somebody who's to an area that's been implicated in an outbreak, or two people go to the same, use the same hot tub. One of them is diagnosed with Legionella pneumonia, and the other person just had mild flu-like illness. We would call that a probable Pontiac fever case. And less commonly, Legionellosis I could also refer to extrapulmonary Legionellosis. Those are rare. Again, it can affect sites outside the lungs. Sites like, can develop endocarditis, wound infections, joint infections from surgeries, graft infections. We don't see that often, so we focus more on talking about Legionnaire's disease than pneumonia. This chart kind of lays out nicely the differences between Legionnaire's disease and Pontiac fever. Legionella usually takes 2 to 14 days after exposure to develop symptoms. It can take longer, though. The symptoms can be similar to other pneumonias, so it can be very hard to detect. Usually have cough and fever, headaches or muscle aches, shortness of breath, chest pain. But often symptoms, they come in with confusion or diarrhea or nausea or abdominal pain. Those can occur also. I've often see a lot of cases that when they first came in, the X-rays, they did an X-ray and it didn't show pneumonia initially, but they did a CT and it did show up, or they did a CT and a day or two later, and after hydration and whatnot, the pneumonia is showing up. They often come in, confusion, with generalized weakness, altered mental status. That can be a sign, a symptom. Pontiac fever, again, is flu-like, low-grade fevers, headaches, tiredness, appetite. It's shorter incubation. It usually takes between a few hours to 3 days after being exposed for people develop symptoms of Pontiac fever. But again, they don't have pneumonia. And a lot of people are surprised to find that, a lot of times the cases come in and the symptoms that they have start with GI symptoms like abdominal pain and nausea or diarrhea. That doesn't make a lot of sense. It's got to do with your lungs. When you're testing for Legionella, a negative urine antigen does not always rule out Legionnaire's disease, because Legionella pneumophila, the urine antigen can only detect Legionella pneumophila. So it could be from other pneumophila 1. It only detects Legionella pneumophila 1. So it could be from other species or serogroups. So the preferred diagnostic testing. Really want to stress that CDC really encourages providers to do a urine antigen test and a culture of lower respiratory specimen concurrently. That can be from just a coughed up specimen or a BAL, but it just needs to come from the lungs. The culturing of a specimen is important because it enables the detection of all the species and serogroups of Legionella. It can detect those species that the urine antigen can't detect. So again, it only detects Pneumophila serogroup 1. Culture also allows for comparison of clinical and environmental isolates during outbreak investigations. The disadvantage is it's technically difficult and can be affected by treatment with appropriate antibiotics, and it's slow. It also requires the special agar, the buffered charcoal yeast, but a lot of labs don't have that. Benefits of urine antigen test are it's fast. It's the most commonly used test. It's fast, it's easy. It detects the molecule of Legionella bacteria in the urine. It can detect Legionella in some cases for days or weeks after exposure, and sometimes even longer in rare instances. The disadvantages are it doesn't allow for a molecular comparison, and it only detects Pneumophila 1. But a patient with symptoms and either a positive urine antigen or a culture or even a PCR is considered a confirmatory test. I get a lot of people who think urine antigen means it's extrapulmonary, but that's only detected if it's isolated from the site. It's made when there's evidence of clinical disease at the site, and then it's detected by culture or a nucleic PCR isolated from the site of infection. So we really try to stress anytime you suspect Legionella pneumonia to do a urine antigen and a respiratory specimen culture concurrently, preferably before antibiotics are started, but don't wait on getting antibiotics started to do the culture. So we culture is the gold standard, and we prefer that. But if culture is not possible, you can also confirm it by doing a lower respiratory specimen PCR or nucleic acid amplification test. In 2020, that used to be a suspect, I believe, but in 2020 they did change the case definition, CSTE and CDC, to include PCR positives as confirmatory for diagnosing Legionellosis and for reporting purposes. PCRs can vary by lab, but they're becoming more common, and so that's why they changed the case definition. It's quick and can detect species and serogroups that other than just the serogroup 1. And it can also be performed on pathological specimens like lung tissue. And again, if patient has symptoms and a positive PCR test, it is also considered confirmatory. DFA labs are very rare. I don't know if I've seen one, at least not in the past 5 years, probably. They can be performed on pathological specimens as well. And they can also detect species and serogroups other than Legionella pneumophila 1. This is supportive laboratory evidence for, so a case would be if they had symptoms and a positive DFA, they would be considered a suspect case. Well, the testing we don't recommend is serology because it's not specific. You have to have 2 specimens, an acute onset specimen and collected, and as well as a convalescent specimen, and you have to have the 4-fold increase between those 2 specimens to be considered confirmatory. So that's not very helpful. And approximately 5 to 10% of the population already has a titer of 1 to 256 because of previous exposures that maybe they didn't make them sick. So that's not very helpful. We highly recommend patients suspected of HAI pneumonia, which is onset of symptoms. We go by 48 hours or more after the patient was at the facility before they arrived or visited. That can be considered an HAI pneumonia, Legionella pneumonia. We recommend anybody suspected of an HAI pneumonia have the urine antigen and the sputum culture or PCR test done, particularly if this patient's been transferred from another facility, like another hospital or a long-term care facility. But unfortunately, a lot of Legionnaires patients have been to multiple facilities, and it gets very complicated trying to figure out where the exposures were, and then usually both facilities have to watch for other cases and monitor. Excuse me. Throat is getting dry. So some of the complications of Legionnaire's disease, Legionella pneumonia, is they are usually have very long. They can't have long hospital stays of weeks or months to completely recover. And some people have a lot of symptoms months after they left the hospital before they actually feel themselves again. Patients are often end up on the ventilator at some point. And 1 in 10, according to CDC, 1 in 10 patients will die from Legionnaire's disease. But it can cause respiratory failure, acute kidney injury, often requiring dialysis, encephalopathy, and neurological changes, and pyemas, where they get the pockets that need to be drained, pockets of pus or fluid that need to be drained, inflammation of the heart, rhabdomyolysis. So healthcare associated Legionnaire's disease is a problem. Buildings have complex man-made water systems that make a perfect place for Legionella to hide and grow. And then, of course, they serve many people, and many people have underlying health conditions when they're at the hospital. Nobody goes to the hospital because they're healthy. In 2017, CDC published it's old, but I thought it really impacted me when I read it. They published this fact sheet in their vital signs. It's a publication they put out every now and then. And it highlighted the impact of HAI-associated Legionnaire disease and the importance of prevention through water management. In in it, they noted that there was, in their data, they found Legionnaires' disease kills 25% of those who become infected by an HAI at a hospital or healthcare facility. And more strikingly, what I found really interesting was that in their investigations, most problems leading to healthcare associated outbreaks could have been prevented with an effective water management plan. This article has been archived, but it's still available if you through the link there. There we go. So CMS in 2017 started requiring facilities to have healthcare facilities have water management plans. Water management plans help control all opportunistic waterborne pathogens, not just Legionella. In 2015, ASHRAE, that's the American Society of Heating, Refrigerating, and Air Conditioning Engineers, they released Standard 188 that recommended building owners and managers have a water management plan. And then in 2016, CDC started recommending it, that facilities have water management plans, a comprehensive water management plan following those new guidelines. And then in 2017, they put out another vital signs article. So Legionella surveillance, CDC does surveillance. We do surveillance here at the state and at the local levels. It's on the rise in the United States, as this graph shows. This older data, but it does show that it is increasing. States must notify CDC of cases. And again, CDC does national surveillance, while here we monitor for increases and outbreaks at the state level. All that information gets entered, gets reported through our national computer system. CDC gets part of the data through that, and then part through a separate case report form, which I'm going to get into that. This slide shows Kentucky data, the case counts and accrued rates. I'm not a data person. My epidemiologist cohort, Krista Mavoli, also helped me go through my slides and get organized. These are based on population size. In 2020, we assume it was underdiagnosed due to COVID, and everything was shut down. Didn't seem like anybody was tested for it. But then as the buildings reopened, we started seeing more cases, which is expected. If buildings are closed, then they're going to be, water's going to be stagnant there. This graph is a shorter time period, but you can see the Kentucky trends align with the national trends with the gradual uptick in cases. We are working on some more data. I say we should be Krista and the data teams are working on updating our data. Unfortunately, Legionellosis disease, we assume it is underdiagnosed, underrecognized. This is where clinicians, healthcare providers, and hospitals can help make sure cases are detected and reported. This allowing us to rapidly investigate public health to rapidly investigate and locate clusters and outbreaks and prevent additional cases from happening. So this is a regulation that, as you probably know, that stipulates that Legionnaires is a reportable condition in Kentucky. It requires priority notification, meaning it should be reported within 1 business day to the local health department where the patient resides. If the healthcare if the health department can't be reached, it can also be just reported to the state health department. These are submitted, it can be reported electronically, by fax, or by phone. So this is how we typically learn about cases. You learn about them in several ways, usually by a positive lab. That's where it starts. But a positive lab doesn't necessarily make it a case. They have to have symptoms that meet case definition. Usually the local health department or the state, we are notified of a positive lab by a provider, a lab, or another state health department if the case was out of state. These come in through electronic lab reports, or what we call ELRs. Those are the easiest. We can get them by fax sometimes, still get those. Occasionally through encrypted emails. We can also receive an electronic case report, which they're working in. These electronic reports come through our NED system, which is how it's kind of like our charting system for patients. Again, the local health department may see these or get these first, or I may see them first and start into an investigation that way to investigate the case. This slide here shows an EPI 200, which is, along with the lab, we ask for an EPI 200 to get demographic information, basic demographic information, onset of symptoms if they have it, if they're hospitalized or not, and the labs that were done. Every case that we get and confirm that it's a case we try to interview. We're a home ruled state, so investigations are conducted locally at the local health department. Once we're aware of the positive result or possible case, the local health department starts this investigation usually. Depending on the local health department, it may be a regional epidemiologist or a local epidemiologist at the health department, or it could be the public health nurse that starts and does this investigation. We have great health department nurses and epidemiologists. They all do a great job. And often the nurses, they all have other duties, but often the nurses are doing the case investigations also in addition to their working the clinic at the health department. But they all do a great job and we appreciate them. So I always say, as soon as you hear about a case, go ahead and contact the healthcare facility and get some medical records, at least the H&P or admitting notes. And we always like to get the discharge notes so we can find out what happened, their outcome, if they survived and were discharged home, or if they succumbed to Legionella pneumonia. After review of the medical records to confirm the case, we want to make sure it meets case definition. Like I said, a positive lab doesn't necessarily mean it's a case. They need to have symptoms consistent with Pontiac fever, or symptoms consistent with pneumonia, or not pneumonia diagnosis to be considered Legionnaire's disease or Legionnaire's pneumonia. Once they've confirmed the case, the local health department attempts to interview every case, or it can interview their proxy, which, as you can imagine, can be difficult, especially when people are hospitalized on the ventilator. It can be very hard to reach anybody. We request that the health departments try to reach the patient or a proxy at least 3 times. And most of them will send a certified letter too, saying the health department is trying to reach you. I also recommend, if they're having trouble reaching, and typically because the patient is admitted, I always recommend to go ahead and try again after they've been discharged. Because oftentimes that's when people will answer the phone after things calm down. Because it's really important to try to get exposures so we can prevent other cases. that QR code, and there's a link to the case definitions I'm talking about. CDC requests that travel-related cases be reported within 7 days. They want to get it noted, the health department or in the state where the travel occurred, the hotel is located, they want to get them notified as soon as possible so they can start their investigation and monitor for any new cases and make sure there's no outbreaks. Once the case is interviewed, the local health department enters everything into our computer system and attaches any paperwork, and that is reviewed here and then submitted to CDC to report all of our cases and our travel. Again, we try to do the travel as quick as we can. So like local health departments are trying to interview all the cases to gain potential exposure history and try to catch outbreaks, as well as collect information about underlying conditions. So that will help us better understand Legionella and Legionellosis. This information is captured and entered in our NED system, but the bulk of it is put into, like I said, the NED system only transmits a little bit of the data, very minimal demographic data mostly, and how it is confirmed by which lab and whatnot. But the exposure stuff is all captured in the Legionella case report form. We had a hypothesis generating questionnaire to gather detailed exposures to help detect outbreaks and clusters. But CDC worked kind of a hypothesis generating questionnaire into their new case report form. So we've started just using that to collect all the patient information as far as exposures, demographic, underlying conditions. We put that all in there on the case report form. Some people still like to interview with the hypothesis generating questionnaire because it has most of the questions on there and it's set up like a script so they can just read it and fill it out. But then that information has to be transferred over because CDC doesn't get everything through the NED system. Once they complete that and attach it, it comes to my queue in the NED system, and I review all the documentation to make sure they do meet case definition. I redact all the information from the case report as far as patient information. So it's not, we're not giving away any patient's personal information. I redact all that and then transmit it to CDC. There are a few questions that aren't in the new case report form that we had on the hypothesis generating questionnaire that I wish were, and I'm hoping we can get them worked in. They're just for exposure histories. They don't ask about like guarding exposure to potting mix or potting soil, using nasal rinses or lady pots, or exposure to windshield washer fluid tanks that are filled with just water. They have found when especially truck drivers fill windshield washer fluid, they don't put the actual commercial fluids in there, and they just fill it with water. That heat can cause Legionella to grow, and then the exposure from the sprays, they can be exposed and develop that way. Those are rare, and they're still monitoring those and learning more about it. All the information is entered in our NED system and that case report, so we can continue to monitor. There we go. So like I said, CDC wants travel cases reported as soon as possible. They preferably within 7 days of notification of a case. That can be difficult to get a hold of somebody within 7 days. But often hotels or travel facilities are implicated in clusters and outbreaks. So it's important that we gather that information and get as much detail as we can on their dates of stay, admission, type of things they did, like if they were exposed to the hot tub or swimming pool, that kind of thing, and get that reported as quickly as we can. Once I get that, I again deduct the patient information, send it to CDC, and they notify the state where the hotel is located if it's not a Kentucky hotel. And then that health department investigates. So we're trying to get all this exposure history. Like I said, we've got some interview tools. We used to use the hypothesis questionnaire. We also use, and it's the local health department people that are interviewing these people and doing all this digging. We have the resident survey that they can use to interview healthcare associated cases that were residents at a long-term care facility to get more details about exposure that are specific to living in a long-term care facility. There's also, CDC has a cruise ship questionnaire if patients were exposed to a cruise ship. And we also have a medical record abstraction form that helps gather information if it's particularly if it's suspected to be healthcare related. So there are different kinds of healthcare exposure, healthcare associated Legionnaire's disease. You can be exposed. We count clinics, hospitals, long-term care facilities, and they have other, which is usually like laboratories or pharmacies if they've had an outpatient. For the purposes of surveillance, they CDC collects this data to keep track. For surveillance purposes, CDC doesn't count assisted living facilities and group homes, but and prisons, senior facilities, but they house at-risk individuals. So we do keep track of those, monitor for cases, and provide Legionella education and prevention information about water management plans anytime there's a case associated with a senior living facility or assisted living, or any of those group homes, prisons. We still keep track because they can't have very large complex water systems and they should have a water management plan. Type of exposure can include inpatient, outpatient. You can also have visitors or volunteers or employees. Just because they weren't admitted doesn't mean it couldn't be at a potential healthcare exposure. So we do keep track of those and monitor for cases to look for outbreaks and clusters that way too. So the different kind of healthcare associated classifications are presumptive, which used to be called definite healthcare associated, which means that the patient stayed at or was in one or more facilities for 10 continuous days during their incubation period, which is 14 days. Possible just means that they were in a facility part of the time, but not the entire 14 days. They may have visited or just been in for an outpatient procedure or to a clinic, or just in for a day or two, but they weren't there for an extended amount of time. Once we learned if we may have a possible healthcare exposure that was there during their incubation period, we review their records to try to determine if it truly is the case. We review each case carefully, trying to weed out any that are not HAI related. We look at onset date of their signs and symptoms, because we're looking for for Legionnaire's pneumonia 48 hours or more after their visit or admission. If they come in and they've already got symptoms, that's not an HAI case. Looking at when was the onset date, if the case was at one or more facilities during that 14 days, how long were they there? Did they leave the facility at all? Were they up and ambulatory? What kind of treatments did they receive? Have they ever had Legionella and pneumonia, or they have a history of frequent pneumonia? Or were there any other significant possible exposures that they could have had that were found in their interview? After, I often end up reviewing these complicated cases with our HAI department or one of the doctors here to try to figure out, if it truly is an HAI. Once we determine if it is an HAI, if I haven't already talked to them, I notify our HAI department for their awareness, because they have regional infection preventionists that are in facilities frequently. And the local health department is notified, and they reach out to the facility and provide the recommendations. We want to make sure the facility is aware that there's been a case potentially associated with them and provide educational information. So again, if it's one possible healthcare associated case, we're going to notify the facility. The health department's going to notify the facility, and this may be done by the nurse, the regional epi or local epi, or environmental. It may be done in person or by phone or by mail, depending on the situation and their health department's resources. If there's been a potential healthcare associated possible case, we're going to recommend facilities monitor for other cases and test any suspected HAIs moving forward to make sure they're tested for Legionella. Review their water management plan and their cooling tower and maintenance records for potential issues that need to be addressed. If it's a healthcare associated outbreak, which would be, we're going to do a full investigation if there's 2 or more possible cases within 12 months or one presumptive case that was there 10 days or more during the incubation period continuously. The whole local health department will reach out and notify the facility. Usually it's recommended the facility, if it's going to be a full investigation, they might want to hire a consultant to help. It's going to encourage that the facility staff and local health department, environmentalist, regional epi, or local epi, and IP work together. The local health department will reach out, provide these recommendations. The recommendations include the facility begin an active enhanced surveillance with daily chart reviews to look for potential pneumonia cases that were not tested for Legionella. You want to look for cases that might have been missed. Notify the providers that there's been a case and to include Legionella in their diagnosis differential, and make sure they're testing any suspected HAI cases, HAI pneumonia cases that have come in, that they test those with the urine antigen and the respiratory culture if possible, or respiratory PCR. It's recommended that the facility do a chart review to look for past cases that were missed, they weren't tested, and keep a line list of those cases and just consider where they were located in the building. The regional IP and facility IP will usually complete an ICAR or WICRA, and the regional IP, facility IP, and epidemiologist and environmentalist will work with the facility to conduct an environmental assessment. Environmental assessment and environmental sampling is recommended for a full investigation, and often that can be done with a contractor. It's also recommended the facility review their water management plan and update that. and then continue enhanced surveillance, monitoring for cases, making sure they're testing suspected HAI pneumonias for Legionella. CDC recommends that public health always be involved in outbreak investigations to provide oversight. All of our recommendations are pulled from guidance from the CDC and what local health departments around in other states recommend doing as well. Every investigation is unique and has multiple steps and planning, and with periodic reassessments. Our public health actions are not meant to be punitive. We're trying to be proactive, get information and resources out there so all the healthcare facilities in Kentucky can have effective water management plans and prevent waterborne disease cases from occurring to begin with. Of course, those also include other bacteria besides just Legionella. So healthcare personnel like providers and administrators, infection preventionists, and environmental engineers are in a good position to monitor your facility. Clinicians can make sure cases are detected, allowing a rapid investigation by public health officials, and prevention of additional cases. Testing for healthcare-associated Legionnaire's disease is particularly important if there's been other cases associated with the facility in the past 12 months, or if environmental testing at the facility has been positive, or there's been changes in water quality recently. In your infection control staff usually have a lot of information on that and could work with providers. These are just some facts about Legionnaire's disease that were mentioned. Like I said, most of them occur mainly in the summer, between May and November, but some are early fall, but they do occur year round, but we see the most later in the fall and summer. It's particularly increased risk for people who smoke and are older and have immunocompromising conditions. Of course, the risk is increased of death if there are a healthcare associated case. And Dr. Nancy Johnson discussed previously many of the factors that can affect building water. So it's important to monitor external factors that may affect the building's water and potentially increase Legionella growth, like the construction or biofilm, sediment and debris, slow moving water. So you really need a good water management plan in place to keep it from growing in there. It's a written document that should be updated and reviewed annually, step-by-step process, and should be developed before cases occur, if at all possible. We're really surprised at how many facilities don't have a water management plan yet, or they have a water management plan that is not specific to their facility. It's just kind of a generalized thing. CDC has a lot of good tools to assist with developing your water management plan on their website. CSDs also has a lot of resources that can help you start your water management plan or evaluate it. And a good place to start, CDC has this free training called Prevent Legionnaire's Disease that can help staff get acquainted with developing a water management plan and a team. And it's intended for anybody associated with a water management plan, which could be environmentalists, engineers, IPs, directors or building owners or managers. We've requested all of the environmentalists at the local health departments and people involved with investigations review this course. It takes about 3 hours, but you can break it down into 30-minute sessions, and you do get environmental credit for it, and it's free. And that is what I have. So we really want facilities to watch for Legionella and make sure they test for it appropriately and have a good water management plan to prevent it to begin with. Any questions?
Does anybody have any questions for Stacy? We also have Dr. Johnson on the here today as well. So if you have any other questions, I know a lot of information was provided over the last 4 weeks related to a water management plan. So I invite everyone to come. We will be putting out days and times for our office hours where Dr. Johnson and Stacy or someone from the Kentucky Department from Public Health team will be able to join us, so that when you're putting together your water management plan and you have questions when you're in the middle of doing it, which in my experience, that's the way that it works. You'll have a resource that you can come back to and ask those questions too. So please look forward to seeing though that we'll send that out either through our newsletter and also on our social media. Anticipate that would be in December, so that you can have a little bit of time to start to put together that plan before we start.